All right, everyone, I think we're going to get started. Well, welcome to our second webinar in our it's our fiscal year 23, but 2022 webinar series. Today, we are bringing together a number of our grantees that were part of our COVID-19 rapid response program that was focused on recovery services and making sure that people stay connected during the pandemic. These grants, were done quite quickly. We closed down our offices here at FORE on March 12th, 2020, and pivoted right away to thinking about what was necessary to help people stay in treatment, stay connected to recovery services during the COVID-19 pandemic. So we have 4 grantees here today that have done innovative work in different areas around that I think you will all find very interesting to hear what those best practices that have come out of these projects are. So my name is Ken Shotskas. I am the program director here at the Foundation for Opioid Response Efforts. And just quickly here, a quick agenda. I'm not going to take too much of your time. We're going to hear from our grantees, Renewal House, Ballot Health, the University of Miami, as well as RTI International, who performed an evaluation of our national emergency effort around COVID-19. We'll end today with a question and answer session. And that's where our webinar logistics come in. So just to make sure, everything that we do, all of our webinars are recorded and are available in our resources section on our website, forefdn.org. We'll make this available quickly after the session ends. The slides will also be available. We encourage you to check out our older webinars as well, as there's a lot of rich content in there. As I said, there's a question and answer session at the end. Please use the Q&A button that's found at the bottom of your Zoom screen to put a question forth. The chat box is great, but for us to be able to organize and to really get to the questions that are that people want to hear most, please use the Q&A box, and please upvote using the thumbs up button on questions that are similar to your own, so we can get to as many as we can during the time as the time permits. There will also be a brief survey at the end of the webinar to help us improve our webinars and our resources, so please provide us with that feedback. Quickly, I just wanted to go over kind of FORE if you're still being introduced to us. To date, we're proud to have given out 67 grants worth $30.8 million across the country through a number of different programs. Our first program was focused on access to treatments, which you can see there. That was our very first program that actually launched in March 2020. As I said, after that, we pivoted to more of a COVID-19 response program where we gave out around close to $2 million, again, to mostly community-based organizations, some universities that are looking at policy changes that happened during COVID, but mostly to community-based organizations that were focused on making sure that services continued and keep people connected to those services. We then launched an innovation challenge where we gave nearly $5 million grants to projects that were looking at some of the most intractable problems around the opioid crisis, where not many great solutions have been put forth. And our latest program is around family community-based prevention that launched in March of this year, $11 million, and really trying to bring prevention more upstream and really target things such as adverse childhood experiences to prevent opioid use disorder down the line. You can see all of our 4 grantees on our website here at this link with new project pages as well, so you can get a sense of what these projects are, as well as see who the PIs are and be able to reach out to them. I want to make a plug for our latest request for proposals that's focused on community-driven responses to opioid use disorder and overdose mortality. We've heard especially during COVID and over the last few years, of the need to support community-based organizations that, for many of them, they're just trying to keep the lights on. So we wanted to be a little bit more flexible with our funding for this RFP. And the goal here is really to help those CBOs enhance their ability to deliver services addressing the opioid crisis, particularly in the hardest hit communities. You could find more information about this opportunity on our website as well. And quickly, just, as in relation to this work, we do publish a lot of different resources on our website. We encourage you to take a look at it. Here are a few of them that are related to this webinar around recovery and being Recovery Month. I think these are a great time to be able to check out some of these resources that have really rich information in there. With that, I want to introduce our webinar presenters today. Again, we have Savik Millis from Renewal House. We have Casey Carringer from Ballot Health. We have Dr. Tukes at the University of Miami and the Idea Exchange, as well as Dr. Kantz at RTI International. And today we're going to start with our grantees at Renewal House. I believe Savik will be presenting, Director of Programs at Renewal House. Take it away.
Awesome. Thank you so much for having us here. We're extremely excited to be able to share our project and some of the things that we found and learned, and some of our success stories also through this. Our CEO also is here, and she's listening on, and that's Ms. Pamela Sessions. So we'll go ahead and get started with the first slide. So I always want to start out in describing a little bit about Renewal House and what we do. We have a very specific population that we serve. So we are a organization, a nonprofit that serves women who are pregnant or have children that are struggling with a substance use disorder. And so this is our motto, that we treat them both, meaning that we are there for the moms during their pregnancies, but also while they're parenting. So we provide recovery groups, recovery skills, and in addition to that, we partner that with evidence-based parenting curriculums and support around how both parenting interacts and relates to a woman in her recovery as she is moving forward on that journey. So next slide. So our project here with that was funded by FORE was to really pivot our system. So Renewal House is 26 years old, and we are very old school, or at least we were very old school before COVID, meaning that we really did not use the telehealth services at all. We had no telehealth platform. And what we saw as COVID hit and lots of places were shutting down and treatment options were much smaller, is that there were so many ladies that were still calling us, still needing the recovery services and still needing to get into treatment. So our goal in our project was to expand treatment access for women that were low income, struggling with a substance use disorder, and hopefully helping them overcome treatment barriers that were complicated or even created by COVID-19 and the pandemic that we were kind of just starting to get into about this time. So our program activities first really started off with a completely free virtual treatment group. And in that treatment group, we utilized really 2 evidence-based treatment programs. So we utilized a program called Nurturing Parenting for families in substance abuse treatment and recovery. And we also use dialectical behavioral therapy. And so we take these 2 really evidence-based programs and we really marry them together. So again, we're putting together the parenting and the recovery in a really practical way, so that these ladies not only leave with ways to move forward in their recovery process, but some really practical ways to manage their everyday lives as it relates to their treatment. Then what we did in addition to those groups is we would check in with these clients individually to assess their challenges, their concerns, and to provide any community provider referrals. So many of these clients were not very close to us in geographic location. So we're here in Middle Tennessee, so we're in Nashville, but many of our clients, they were coming from far west Tennessee, as far west as Memphis or 3 hours in the other direction. Tennessee's a very long state, and we're ever in like Appalachia. So it's it was really important for us to be able to find additional referrals in their community that were open that could also address some of those very practical things that they were concerned about, that we all know impacts their recovery, right? If they don't have enough food, if they don't have stable housing, if they don't have a support system. And then the third component of this was to increase access to treatment and healthy recovery supports through implementation of new technology and, of course, the telehealth platform. None of this would have been possible without FORE. One, we didn't know what Zoom was when COVID started. Maybe a lot of other people did, but Renewal House was not in that category. So we had to learn what Zoom was. We invested in a good amount of new technology and training our staff how to use it. And so this was a really huge component to the success of our program. And then the population that we were specifically targeting with these telehealth groups were women age 18 and over, and we are especially focusing on those that are pregnant and postpartum. Now, our postpartum definition is 12 months past the delivery of your child, but of course we serve women that have 7 or 8 year olds also, but we were specifically focused on pregnant and postpartum women. And then we really wanted to have outreach into those rural communities with limited treatment options. Next. So here are some of the process measures, and really kind of get into the number of individuals that we were able to touch. And so the project connected with 67 community partners across the state of Tennessee. That was really step one for us. It was reach out, find out who's out there. How can we be sort of the center of this really amazing map where we can pass out resources all across our state? How can we connect with partners that can give us referrals? But then how can we know who that we can tell these ladies to reach out to in their own communities, in their own rural counties? So we found 67 community partners that loved to hear what we had to say, and we wanted to hear what they had to say. We also increased our agency's ability to provide services via telehealth to more than 87 clients, which is pretty amazing. We're not a large agency, so this is a big number for us. And we allowed 92 mothers and their children in our long-term comprehensive family residential treatment program. Our flagship program is residential treatment, to increase their ability to connect with healthy recovery supports, family members, and offsite children. So in addition to this piece of technology that we added, this platform being able to be utilized for this telehealth group option for the women in the community, we also had a dual purpose in that we use that same technology to allow our residential clients to connect with their family members. Because of course, at the beginning of COVID, we really weren't kind of sure what was going on. Of course, we were still open, but we wanted to keep our families safe. So instead of saying no visitation options, we said, let's do this virtual, right? Let's have family members visit virtual. Let's open up to 12-step groups all over the world, all over the country, so that our ladies can be engaged and still find healthy ways of living in their community, even during a time when we felt isolated. And then in addition, the project enrolled 41 women in our telehealth treatment program, and we started a telehealth group for female inmates in the Davidson County Jail. So that is Davidson County here in Nashville. It's one of the larger counties in the state of Tennessee. And thanks to FORE, we started this, but really exciting news that we have been able to sustain this partnership with the Davidson County Sheriff's Office and continue to serve women through this telehealth treatment program while they're incarcerated. Next. So just a couple of data points on some of the participants in our telehealth group program. We actually had 12 ladies completely graduate, and that means they attended at least 8 weeks of our group. 3 of our participants, I think out of the total 41, actually regained custody of their children. So that means for some reason DCS or Department of Children's Services had placed their children outside of their custody, and through this program, through our support, through gaining this treatment, they were actually able to regain custody of their children. And then if you can see sort of this section in the middle with the bar graph, in the beginning, we estimated that around 50% of the individuals that we worked with via telehealth, we would see a decrease in their scores on the DICE, which is an evidence-based assessment used to assess substance use, and the frequency and method in which you're using substances. And our actual outcome in those pre and post tests, we actually saw that 90% of the individuals or the ladies that engaged with our program saw a decrease in substance use, which was really incredible. And then the last section here at the bottom is this is a very unexpected finding for us, is that 45% of our clients that ended up graduating, they chose to continue with our program. So even though they had graduated, they didn't have to be there anymore. They actually chose to continue. And that really helped us see that they found the value in the program. We as a treatment provider hope that our program is very valuable, but when someone graduates and decides to stick around when they don't have to, and maybe the legal system or outside forces aren't encouraging them to do so, really shows that they're really hungry and that strong desire for recovery. Next. So lessons learned. These probably seem simplistic now in hindsight, sort of Monday morning quarterback style. But if we really want to go with the lessons learned from way back in the beginning of COVID, here in the state of Tennessee, internet challenges, especially in our rural areas, continue to be a really big struggle. And that includes phone service. And so we sort of expected that clients would have internet, or they would be able to use the free phones that the government provides for internet. And while that was the case, we found that some of our counties are indeed so rural that service just is really non-existent. We also learned after about the first few months that a virtual platform for signing documents is almost a necessity. It is really helpful. We ended up with DocuSign, which I think a lot of people went to, but that was incredibly helpful for us in getting those initial documents back so that clients could enroll in the program. And I think that this next one was a little surprising to me. Even during virtual meetings, childcare is a barrier, right? And so I think we often think that being virtual, it removes a lot of barriers, and it absolutely does. But I think that we often forget that even when a child is still around, moms aren't necessarily as honest as they could be, or a child's climbing on their head and they can't focus as much. So we still also saw that childcare was still a barrier, but it was much helped through the use of the telehealth program. And then something that we also learned is you really need a protocol for the virtual sessions before you dive into providing those groups. And then so I just listed some of the things here that that sort of we had conversations with our clients about, like no sitting on a bed during group, you can't be riding in a moving car, lots of things that you don't think about when someone's physically present with you, but you have to think about when you're doing things virtually. And when the last is just when you remove a barrier, sometimes other barriers presents itself, such as establishing a support network and attending meetings. So that remained a barrier, even though we were providing a meeting. There wasn't a lot out there in the beginning, and thank goodness that has much improved as COVID has gone on. And lastly, a really positive thing is our clients are incredibly resilient. We just learned through the pandemic, we hear a lot of negativity on the news, and, we know those things are certainly out there and true, but we just found a lot of resilience in our clients. We found the hunger to be in recovery was still very strong during the pandemic, and they really had a strong desire to engage. And I think there's one more slide. So these are the opportunities, and I kind of said they're limitless because these are the 67 partners that we engaged with across the state of Tennessee and still engage with now. It's not just to reach out one time and then turn it away. So the possibilities are truly limitless if you allow them to be. And so I think I can wrap it up from there, and let me introduce from Ballad Health, Casey Carringer.
Thank you, Savick. Good afternoon, everyone. It's truly an honor to be here this afternoon, and just excited for the opportunity to talk about our program. So just really quick, who is Ballad Health? So we are a merged health system across Northeast Tennessee and Southwest Virginia. So there you can see on the slide sort of our footprint, if you will. We typically really focus on our 21 counties in far Southwest Virginia and the upper 10 in Northeast Tennessee. And we were made possible through what's active oversight. We were two health systems that operated independently of one another in our region, and we merged to create one health system. And so in order to merge, we have to have oversight from our committees on both Virginia and Tennessee to ensure that the merger of the health system is truly for the public advantage. To kind of give you a very brief idea of our health system size, we're around 15,000 plus team members. We're the 4th largest employer in Tennessee. And at the time, we are the 9th largest healthcare organization in the United States. We have 21 hospitals, long-term care facilities, outpatient addiction treatment facility, outpatient services, home care, hospice services, retail pharmacies, and a comprehensive medical management group. So that gives you kind of an idea of who Ballad is and the organization that I work for. Today, we'll be talking about Peer Help. So Peer Help is a program within Ballad that I have director level oversight of. And just to give you an idea, our Peer Help's mission is to seek to improve the quality of life for individuals in treatment and recovery from substance use disorder by addressing their health-related social needs through tailored social support, resource navigation, and advocacy. And our vision is that we envision that all people returning from incarceration or treatment for substance use disorder will have a seamless reentry into society by having the necessary resources and opportunities to succeed, and therefore reducing the morbidity and mortality of substance use disorder in recidivism in the Appalachian Highlands. The Appalachian Highlands is what we call our region there that you saw on the map prior to this slide. So one of the themes that we really employ as Peer Help, and many of you probably have heard the saying before, nothing about us without us. Peer Help is designed to be an inclusive program for people in recovery. We currently employ 12 certified peer recovery specialists, soon to be a total of 15. And of those certified peer recovery specialists, our staff possesses over 20 years of incarceration experience personally. Our program, we really embody the idea that everyone has a right to be involved in their own recovery process, and we respect all pathways to recovery. We've worked to diversify our staff so that we can mirror more of our community. So we do have staff members who are members of the LGBTQ plus community. We've worked to have ethnic and racial diversity amongst our team. We do employ some young adults, and obviously our staff have all had various pathways to recovery themselves. Peer Help, we have 4 service lines, if you will. We provide trainings, community navigation, warm line. We have a warm line and recovery meetings. We'll talk about the trainings first. So first, I'm assuming most are familiar with this, but what is a certified peer recovery specialist? So in the states of Tennessee and Virginia, a person must be at least 12 to 24 months with lived experience and in recovery from a substance use disorder or mental health challenge. On Tennessee side, it's 12 months. The Virginia side, it's 24. It is an evidence-based practice. Our community service boards and other employers in our region do also offer peer services. And when the person goes through the training and then they become certified after taking an exam through either the Tennessee Department of Mental Health and Substance Abuse Services or the Virginia Certification Board. On the Virginia side of the certification, there is a 500-hour internship required. So the pathway to becoming a CPRS is that a person should be in recovery. They will then go through the training, which is 72-hour training, and then have to have a 500-hour internship. And then at that point can sit for certification through an exam. What was occurring that we found personally, just anecdotally, and then the Virginia Commonwealth University did a research, is that they were finding that many people were going through the training. So they would get trained, but then they would never become certified. And so what they identified is that there was a significant barrier for folks to get the 500-hour internship. If you work in healthcare, you already know how hard it is for even nursing students to get internships. So then you put into play someone who may have a criminal background, and then the doors close across, many sectors and many organizations for allowing that 500-hour internship opportunity. So they identified this. In addition to that, as you can imagine, COVID-19 then significantly increased the barriers because many of the potential sites that folks could volunteer were unable to have in-person services. So at the same time, sort of as COVID hit, we were identifying through the study that there was an issue with these 500 hours. And so at that point, we decided what could we do about it as peer help. We are, as I said, very rural. We're in far Southwest Virginia and Northeast Tennessee. And what we found is that across Virginia, we're the most significantly impacted by substance use disorder, but we had the fewest number of certified peer recovery specialists. If my memory serves me correct, it was around 5% of the entire state's certified peer recovery specialists at that time. And so it was very concerning to our program at Peer Help. Obviously, that's our pipeline to employment, and many people that are seeking recovery and employment really wanted to become CPRSs. Next slide, please. So in comes the FORE funding. So we've identified that we have this issue that folks can't get their 500 internship hours. We've identified that in addition to that, now we have this great thing called COVID in which people can't even come in person. So at that point, we were made aware of the FORE funding opportunity and were awarded. And what's really great is that the FORE funding allowed us to stand up the warm line, which I'll talk about in a minute, and B, workstations all across our footprint. As you can see on that map, we have a large footprint. We are very rural. So just in Southwest Virginia to drive from point A to point B, maybe over 2 hours one way. So we really needed to embed these workstations across the footprint so that people could come to the workstation and work and get their 500 hours. And we would be the entity they would volunteer with, because we were understanding and agreed that some folks may have a criminal background, and we were willing to work beyond that and work through that. In addition to that, it was a win because we went to our county community partners and we said, for example, Emory and Henry College, would you all lend us an office space if we would provide equipment and the peer could come in and work on our warm line, electronic tele? They could also respond to emails from folks who are incarcerated, and they're going to be co-located in your college. So now you have a peer at your college for free who's been trained to access, for your students. So it was really a win-win for everyone. The person seeking the opportunity to have the 500 contact hours had an opportunity to do so. We obviously were able to expand our work staff through these volunteers, and the community partner that we partnered with now had a peer embedded in their facility without, free of charge. So it was great. With that being said, we trained peers. So we trained folks not only in the certified peer recovery specialist curriculum, but we also trained them in facilitating meetings. So different meetings, whether that's faith-based recovery meetings, smart recovery, MRT. They were going through the training to become a peer, but also learning how to facilitate recovery meetings. So we had these interns. They could either, work the warm line, answer the phone calls that came in. They could answer jail emails. So we have an email account we fund that folks who are incarcerated can email us, or they could facilitate recovery meetings virtually, because what we also found is we all, of course, felt very isolated, but folks in recovery who had really depended on recovery meetings were now ending. And so we were able to provide recovery meetings for our community and expand support services, as well as stand up the warm line. So it was a wonderful opportunity been provided. And we actually still continue all of those services to this day. We've been able to serve 40 plus interns through this opportunity. And next, other trainings we offer Narcan trainings, again, certified peer recovery specialist trainings. and Workplace Excellence Series, which are work ready trainings. And we actually offer those inside our jail systems. Okay, next slide, please. We also offer community navigation. This is an infographic here that really outlines how we utilize peers in our program in addition to these other services. As you can see there, law enforcement, hospitals, EMS, jails, prisons, employers, etc. They can be referral entities into our navigation. And then you see the hub there, which is staffed by peers. And so we go hand in hand with each person we serve, our participants, and navigate them to needed services with the ultimate goal of gainful employment. We connect them to primary care providers, dental, vision. We also work with our workforce development boards to identify any training or education that a person may need. And one of the sources or referral inputs into this navigation hub so happens to also be the warm line that we were able to create due to the FORE funding. Next is the warm line. So this is a flyer here for the warm line. The reason it's not a hotline is because we do not staff it with peers from midnight until 8 a.m. But we do have it roll over to our respond line. So there's always a person that someone will get on the other end of the line. And they can call, a person can call for services and a peer will be there to support them. Recovery meetings, which I've already touched on just a little bit. So we do have diversified recovery meetings. We offer SMART recovery, living free faith-based meetings, moral recognition therapy, pathways to recovery, which is a self-help recovery meeting, Narcotics Anonymous. We also have LGBTQ plus meetings that we host at various pride centers. We also have a recovery meeting that's for folks that work in the food and bar industry. So those staff, we actually hosted at a downtown restaurant, and so that we can serve folks who work in that industry. We also have the Workplace Excellence Series, Contingency Management, Botman Life Skills, which focus on youth, and parenting and family classes. Very quickly, this is just an overview of the Tennessee services. So those are our counties in our Tennessee footprint, and you can see the services that we provide there by county. We do have peers in our EDs in 2 of our counties. And the same here for Virginia. So you can see the services we provide by county in our Virginia footprint. So lessons learned, community collaboration is a must. We've definitely learned that, by working to get community buy-in and working with our community partners, that our programs are always much more successful. Of course, nothing about us without us. As a person who's not in long-term recovery, I think that that's something I've certainly learned. For example, the email system in the jails, I, had dreamed up this great idea of that we would correspond with email. And my staff in this program, who were all peers, politely let me know that you have to pay to receive and send emails. So while I had this great, well-planned program, we had to think through, well, how would we prepay emails so that we could overcome that barrier, in which we do now. We have grant funding that we pay for email accounts so that folks can contact us for free and we can respond vice versa for free. So I really think, nothing about us without us is so important. I like I said, I'm not a person with lived experience in recovery, but I'm so thankful that we have folks on our team that are, because it's really helped make sure that the program that we're developing truly serves the population that we wish to connect with. As you can imagine, our entire team, including myself, are very passionate people, and sometimes patience is not a virtue. So we've really had to work hard to, although we're passionate, practice patience, be intentional about what we're doing as we roll out new service lines. For example, one of the things with the FORE grant funding that we had planned to do was, as I said, the warm line is not 24 hours. We had hoped initially that we could actually utilize the incarcerated population to be able to volunteer for the warm line in the 3rd shift. So essentially we would be able to train folks who are currently incarcerated with SU that are in recovery from substance use disorder as certified peer recovery specialists. So when they came out of incarceration, they had that skill set. And in order to get their 500 hours, they could have staffed our hotline on the third shift. We are very excited about that opportunity, but with COVID and staffing shortages across the nation, it has been very difficult to implement that. We're still hopeful. We're not giving up on that, but we learned quickly with the jails that when they have to move populations around in the jail, that it takes a lot of staff and a lot of staff time. So it's very difficult. So while we're passionate, we're trying to practice patience and just be adaptable and flexible. Like I said, the jail services, we had initially been doing our navigation enrollment in person. We were doing a lot of in-person support in the jail. And when COVID came along, we had to switch to virtual. And that, you know, for those of us, many of us that work in this industry, I think virtual was pretty easy. We'd already been a part of Zoom meetings and things like that. But for the jails, that wasn't something that they were very accustomed to. So we had to work through a lot with the jail administrators and getting them to buy in to utilizing Zoom and virtual platforms. And yes, so thank you very much. And it's my pleasure to introduce Hansel Tooks with the University of Miami Miller School of Medicine.
Thank you very much, Casey. And thank you to all of you for coming today. Thank you to FORE for funding all of this amazing, innovative work. It's a really, it was tough times there in early 2020. And I like to see that nationwide, we were making very technologically appropriate switches to telehealth during that time. So I'm going to talk to you today about the rapid implementation of peer navigator-led telemedicine for medications for opioid use disorder in response to COVID. So my students came to me as soon as they were pulled from their rotations. One thing that most people don't know is that medical students were actually nationwide pulled from their rotations other than in New York City as soon as the pandemic hit, because there wasn't enough PPE and there was also unknown risk to the medical students. So they were all pulled from their clinical activities and they were home. And so when I leave this talk, I go over to our local syringe services program, the Idea Exchange, and we do our low barrier buprenorphine clinic on Thursday nights. The students were despondent. How will we help people with opioid use disorder? We can't volunteer at the needle exchange. We're all at home. We feel helpless. So many of our participants were losing their jobs, were losing their insurance. Many people were coping with substances, and my students wanted to help. So they decided that they were going to implement telehealth-based delivery of buprenorphine at the syringe exchange, and that we would use peers to bridge the digital divide. This was made possible because of the relaxation of buprenorphine prescribing regulations by SAMHSA and the DEA that were implemented at the beginning of the pandemic. Unfortunately, those all expired last summer here in Florida, but this is just a flyer that my students came up with as we embarked upon our telehealth journey. Next slide, please. And it was successful, so successful that we were able to publish on it. This is a paper with Marcus Castillo, one of my phenomenal fourth-year medical students, on implementation of this medical student-run telemedicine program for medications for opioid use disorder. Next slide, please. So a little bit of the descriptive statistics of our program. So we were able to assess 22 people at the time that we published this, this manuscript. And it was the majority men, just like our program. We had 43% white, 38% Hispanic, 19% non-Hispanic. There were about half and half people who injected drugs, and the majority of people injected opioids, heroin, fentanyl. And of course, it's Miami, so there is a very high prevalence of HIV, 14%, and it's a needle exchange, so there's very high prevalence of hepatitis C. These demographics were concerning to us, sorry, Ken, just because we have always been a program that, that has wanted to make sure that we seek equity, health equity in Miami. And we were concerned that we were not reaching enough Black participants that were struggling, that are disproportionately affected by the overdose crisis. So then we came to FORE to ask for funding. Next slide, please. Just to show you the flow diagram of this clinic, there were 31 patients who used our online portal to request an appointment, and 22 were scheduled by a student. You can see the reasons that there was the drop off of 9 participants there. All 22 were evaluated by a medical student and a physician. So me at home in my apartment downtown, the students in their apartments, and the participant, whether that be at IDEA or on the mobile unit, interacting with our healthcare system. 15 of those participants were prescribed medications for opioid use disorder, and 12 had their medications dispensed. But as you can see here in this flow diagram, it was 9.5 days on average from the time a patient requested an appointment to the time that they had their life-saving medications dispensed. So there were many logistical implementation strategies that were able to be supported by FORE as we move towards building a more robust telemedication for opioid use disorder clinic. Next slide, please. So what barriers in general exist to healthcare for people who inject drugs? And so this slide was adapted from an article in AIDS and Behavior by Singer and colleagues. And it basically is an adaptation of Merrill Singer's syndemic theory. And it shows the psychosocial and structural burden faced by people who inject drugs. You have the syndemic health problems of HIV, Hep C, substance use disorder, mental health disorder, and intransigent stigma. All of that complicated by COVID. Then you also have this psychosocial and structural burden, racism, loneliness, our historical lack of access to harm reduction services here in Florida, lack of access to technology, lack of social support, of course, pandemic-related stress, homelessness, and trauma. And all of these served as major barriers to entry to care for people who inject drugs. So much of our time in early 2020 was figuring out how we would overcome what seemed to be insurmountable barriers to access for care for the people that we serve. I should have mentioned to you that the Idea Exchange, where I work, and the syringe services program that I founded was the first legal syringe services program in Florida. So it's been an honor to really move towards this new era of innovation, building upon evidence-based medicine, now innovating in order to adapt to our new world. Next slide, please. So we developed an innovation called teleharm reduction. And of course, it builds upon harm reduction, which is meeting people where they are, both mentally and physically, respecting their autonomy and treating them with dignity, respect, and I like to say love as well. And we developed an intervention called teleharm reduction, as we were all at home on our computers, as we are now. And what teleharm reduction is it's telehealth enhanced, on-demand delivery of services. It's low barrier access to medications for opioid use disorder. We're able to prescribe antiretrovirals, medications for hepatitis C. If we have to draw blood, we have phlebotomists at the needle exchange program or on the mobile units. We have peers that are able to give counseling and provide medication management. Many people don't realize that people who are experiencing homelessness, their medications are confiscated, their medications are stolen. There are so many issues that they have related to that are impediments to their success on medications for opioid use disorder. So what the FORE grant did was it allowed us to hire a peer, somebody from IDEA who is in long-term recovery, and he was able to manage people's medications. So storing medications at the syringe services program in little mailboxes, allowing people to access the mailboxes when they were accessing their syringes, delivering those medications to people in the field. All of this was delivered via the syringe services program, integrated with evidence-based naloxone and injection equipment. So basically, we were adding a telehealth intervention upon 3 decades of evidence that syringe services programs are effective in the prevention of HIV and hepatitis C. We're leveraging the syringe services program to be able to improve access to life-saving medications for opioid use disorder. Next slide, please. So just to drive it home, so what is teleharm reduction? So there's the physician there's the peer, excuse me, the peer is that the patient is at the center. That's the most important. The patient is at the center. And then there's a peer who brings an iPad and connects the patient with the physician who's able to prescribe life-saving medications, which are delivered with syringes and life-saving naloxone. Now, this is important because people who inject drugs sometimes go between using medications for opioid use disorder, injecting drugs. We celebrate any positive change, any reduction in substance use, any reduction in the harms that people are experiencing is a victory. So, but this is a truly authentic intervention in that it acknowledges that people will go from injecting substances to using their medications for opioid use disorder and vice versa. And so this allows for continuous motivational interviewing by the peer so that we're able to assist the patient on their path to recovery. Next slide, please. So what did the FORE funding lead to? And I know that Ken and Karen, Dr. Scott, I don't know if you're here, everybody's very excited about this. We were able to leverage our FORE pilot funding to contract with our state SAMHSA recipient. And basically now we have a $700,000 a year allocation from the state of Florida to provide low barrier buprenorphine via our syringe services program. So we have the Bright Idea Clinic, which is the buprenorphine initiation and treatment experience. And basically this allows for us to co-locate both syringe services and access to these life-saving medications. So much so, and I'm not going to talk that much politics right now, but our governor had representatives from his office and the secretaries of his major healthcare agencies come to visit our low barrier buprenorphine clinic so that they could use this as a model to replicate it across the state because we've had such astounding success. Next slide, please. So now with our funding and our ability to overcome barriers such as transportation and inability to pay for these medications, in our first year of Bright, we served 161 participants. 107 of them were uninsured. 54 of them were insured. We conducted 253 physician visits with the uninsured patients in 2021. 325 times did my team go to the pharmacy to pick up medications for people that we were serving in our clinic. And our 3-month retention in medications for opioid use disorder on buprenorphine is 56%, which is extraordinarily high given the high risk of the people that we serve. So we're very, very proud of these numbers, and all of this became possible because FORE saw us as innovators and trusted in us to use the funds to leverage them in order to make a sustainable pathway to recovery for the people that we serve. Next slide, please. However, we were not able to serve as many Black people who inject drugs as we had intended. This was always, we all know that there are extraordinary disparities in access to medications for opioid use disorder for Black people who inject drugs versus white people who inject drugs. In fact, the literature is all focused on, there is very little focus on the community of Black people who inject drugs. So in our challenges, I'm sure that our colleagues at FORE will be very happy to know we have recently completed 30 interviews with Black people who inject drugs who use our program and conducted qualitative interviews to see how we could better reach the community. And we identified 3 themes. One, our participants felt that our mobile unit would be a safe, confidential, and comfortable location for receiving medications for opioid use disorder and PrEP as part of comprehensive HIV prevention services. They wanted us to have a one-stop shop. The second theme that arose from our qualitative interviews was that our mobile unit was more accessible than other substance use disorder or HIV treatment facilities, and that our accessibility could be further enhanced through strategic locations and hours. The hours was something that we hadn't thought about, returning to the same place multiple times per day to reflect different people's migratory behaviors and their sleeping patterns. The third theme was that participants strongly desired a staff who were a syringe services program, SSP staff who were caring, non-judgmental, appeared approachable, and had lived substance use disorder experience. Many people identified injection experience in particular, so that people could understand the intersecting stigmas that our participants experience. It's interesting, though, something that was very surprising to us was that most participants had no racial or ethnic preference in the peers that were delivering the intervention. So we have done this in order to better work in pursuit of health equity and reach the community that we had intended to when we applied for our FORE funds. Next slide, please. Oh, here we go. Ken, can you hit play? Oh, no sound.
I think I can fix that if I just unmute it. See if this works.
Reduction was started by people who use drugs to save each other's lives. Here on 7th Avenue, right under the sun in Miami, is Florida's pioneering syringe service program, the ID Exchange, where tools like harm reduction, advocacy, and compassion are being used to save lives. At the intersection, stories of research, compassion, and HIV services for people who use drugs. At the intersection where compassion meets community, harm reduction takes on a more active role to avoid negative health outcomes. And it does so by meeting the community where they are at.
Harm reduction is basically bettering a person's life and the whole community.
Harm reduction to me is being able to go to a place and get clean stuff to use and not have to rely on going to a street and buying it, or hoping you're getting something clean or whatever it is.
Harm reduction is understanding the world of the other and immersing yourself in it for long enough to understand from their point of view. Meeting them where they're at.
Just like we meet people on the street with syringes, I meet my patients by kneeling down. You just have to do what you have to do in order to be on that level and be on the safe wavelength of the people that you're taking care of.
Harm reduction to me is making sure our people here are taken care of.
Harm reduction is basically just having a place to go to or people to talk to about anything and everything.
Harm reduction is giving more because that's what they need in the moment.
Suboxone. Suboxone is a medication used to treat opioid use disorder.
They offer Suboxone to help you get off or whatever it is. They work with you here. And I just think that's amazing because really we didn't have a place like that.
So the studies that show people who use SSPs are 5 times as likely to enter treatment. Syringe services programs like ID Exchange can provide a range of services, including sterile syringes, vaccinations, HIV testing, and help accessing substance use treatment. Nearly 30 years of research shows syringe services programs are safe, effective, and cost-saving tools that can prevent HIV and other complications among people who use drugs. Last night, that we started 12 people on Suboxone, and those are people who otherwise would not have had access to this life-saving medication, and now they're on their road to recovery. Harm reduction is the first step in recovery. Syringe services is the first step. But now we have the ability to start people on life-saving medications for opioid use disorder. We're helping people in their recovery, but wherever they are on that spectrum. We have to respect the autonomy of our patients and understand that our one way of doing things does not work. We have to adapt and have a personal approach for everybody that we serve.
Harm reduction is holding someone by the hand and saying, you're gonna come with me because I have the time to commit to you because you're worth it. And so what do you need? Do you need to go to detox? I'm gonna go with you.
We've got this team that treats you with such dignity.
Did you get them to the door? Did you follow up 2 days later to make sure they're still in treatment, or did they fall out? It should be, hey, I'm in this journey with you. You've now met me. You seem to want to do something to better your life, and I'm gonna support you. Let's run that mission.
Harm reduction is understanding and compassion and strength and very nuanced.
For harm reduction, it's love.
All right. Well, thank you for indulging me in that video. It was very exciting. NIDA produced this series of videos based on the work that we were doing, and obviously it was filmed during the pandemic. And I wanted you to have a chance to meet Arrow, and Arrow was the first peer that we hired at IDEA, and we did it with our FORE fund. So thank you for bringing Arrow onto the other side of the curtain. It's so nice to have him on staff at the University of Miami. Next slide, please. So with that, I have many people to thank. Many of my colleagues, my mentor, Lisa Metch, my co-PI and everything that I do, Tyler Bartholomew, and my colleagues at the Florida Department of Health and now the Florida Department of Children and Families, our SAMHSA recipient, for believing in our program. And thank you to FORE for investing in us, because we've had amazing returns. So thank you so much. And with that, I get to introduce Jessica. So Jessica is going to talk to you about the evaluation of FORE's COVID-19 National Emergency Grants. And thank you so much. And to you, Jessica.
Thank you. And so I will be wrapping up all of the discussion today by providing an overview of the 9 grantees that were funded. So you've just heard from 3 of the 9. So before I begin, I wanted to acknowledge my team, some of who are actually in attendance today. So our team included Dr. Philip Graham, Sarah Haregrove, Katie Hennessy, Chelsea Burfiend, and Dr. Sheila Patel. Next slide. And so this project, our evaluation, was a developmental evaluation with 4 main goals. And so as a developmental evaluation, we were focused on understanding these real-time adaptation efforts of the grantees, rather than systematically assessing either the efficacy or the effectiveness of the activities. And so our overarching goal was to develop recommendations for future grantees, as well as recommendations for the foundation to consider when developing new funding opportunities. And so today I'm just going to provide some highlights of our findings and, most importantly, end with our recommendations. Next slide. And so FORE provided a little under $480,000, which was split amongst the 9 grantees. And so these grantees were funded between July and October of 2020. And RTI, my organization, was funded in March 2021 for the evaluation. And so, as you can see here, most grantees did focus on transitioning existing services from in-person to virtual settings. And as you've just heard from the 3 grantees before me, each program had varying program activities and target populations. And so one of the benefits of the funding was the ability for each grantee to determine the greatest need for their community. Next slide. And so our evaluation findings and recommendations were based on 3 data sources. So first, we conducted 2 rounds of interviews with the grantees. The first round of interviews were conducted in the spring of 2021, and the second round occurred in the fall of 2021. We also led a meeting with 8 of the 9 grantees in September of 2021, which included lightning round updates from each of the grantees who, each shared activities and achievements to date. And we also had small group discussions about client engagement, evaluation, and sustainability, as one of the attendees asked in the Q&A. And finally, we gathered information from reports that grantees submitted to the foundation. Next slide. And so we started our evaluation with the development of this conceptual model. And this model is a combination of 2 frameworks. So first, the social ecological framework is a public health framework, which is based on the understanding that successful engagement and long-term recovery is influenced by an interaction of factors, which vary from individual characteristics to community norms, policies, and broader socio-political issues. Now, the Consolidated Framework for Implementation Research, or CFIR, is an implementation science framework that organizes constructs associated with program implementation effectiveness. So our developmental evaluation focused on these dark blue boxes. So organizational characteristics, program characteristics, and organizational outcomes. But we wanted to make sure that we were acknowledging that these programmatic factors really interact with community, interpersonal, and individual characteristics. And all of these complicated interactions are what lead us to the ultimate outcome of interest for this funding, which is successful long-term recovery for individuals with opioid use disorder. And so I'll now go through the highlights of our findings. Next slide. Thank you. So the first set of themes was related to the external factors influencing the grantee programs. So not surprising, the biggest challenge was the pandemic. That's why we were all here. And specifically, we saw, facilities were shutting down or had reduced numbers. We saw that mutual support groups had to stop meeting in person. Or, as we all know, the pandemic directly impacted the physical and mental well-being of individuals with or at risk for opioid use disorder. And so, however, though, at the same time, federal and state policies changed due to the pandemic in ways that actually supported grantee activities. So, for example, we saw that in some states, providers were now able to bill for telehealth services at the same rate as in-person visits, which had not existed before the pandemic. And grantees also discussed multiple aspects of how FORE, the foundation, specifically facilitated their activities. So in addition to the rapid turnaround funding, which allowed them to respond to real-world challenges, the funding was also flexible so that grantees could use funds for technical infrastructure, such as Zoom licenses, as we were hearing, and hardware. And so we saw, on average, grantees spent about 16% of their budget on this type of infrastructure, and it ranged to almost 50% for a couple of grantees. And the grantees also appreciated the hands-on approach that FORE was able to give during the development and implementation of the programming. So we saw from the grantees that this hands-on approach was really important. As we were hearing, everything was changing on an almost daily basis. And so to be able to have that communication regularly with Ken and Lydia and Karen was really beneficial. Next slide. And so the next findings were related to those organizational characteristics. And so as both Casey and Hansel were mentioning, overwhelmingly, grantees discussed the importance of employing individuals with lived experience, specifically with opioid use disorder and long-term recovery. And so what we saw were that these individuals were highly engaged and were also able to innovatively approach the challenges that they were faced. Partnerships were also critical to grantees. So as Savik was noting, enhancing long-term relationships, but also finding new and complementary partnerships to ensure that you weren't having duplication of services during these challenging times. And so what we saw, though, in terms of the biggest challenges, were often seen among the smaller organizations. Next slide. And so finally, we were documenting challenges specific to the programs. And so as we've all experienced, having to move into this virtual space has been challenging. And we saw that grantees had to train up staff to use Zoom, and more importantly, learn how to shift skills such as facilitating mutual help groups virtually rather than in person. And what we saw from across the grantees was that clients seemed to be really actively engaged early on in the programs. And this was probably because we saw that social connection was really lacking. And so people were excited to have the opportunity to meet, if not face-to-face, at least see faces. But over time, as I think most of us have experienced, they also saw Zoom fatigue. However, despite this, all of the grantees plan to continue using virtual services in at least some way. And instead of it being an either or, grantees plan on doing in-person and virtual. And grantees noted that transitioning to these virtual services is likely going to increase reach to underserved populations because it does decrease barriers such as transportation. We did also see that internal capacity was sometimes challenging for some grantees, particularly when it came to evaluation and sustainability efforts. But despite these challenges, as we heard from Hansel, some grantees have been able to secure funding to continue the program activities that they began with the FORE funding. Next slide. And so from our findings, we developed recommendations for organizations and also the foundation. So this slide presents our recommendation for organizations. And so again, one of the clearest recommendations across the board is to employ staff with lived experience. So as Casey was saying, nothing about us without us. And so in addition to being committed to the mission of the organizations, individuals with lived experience with opioid use disorder develop strong connections with clients and were able to navigate those challenges through innovative problem solving. However, I do want to note that we did have a couple grantees discuss the challenges of hiring individuals with lived experience, given policies such as state barrier laws, which prohibit employing individuals with a felony conviction. So I think this is something that we'll still have to think through as a cohort. Now, even with a strong staff, organizations can't do everything themselves. And we saw that the grantees were most successful when they were able to build upon longstanding partnerships or build complementary partnerships. So again, talking about coordinating with other organizations in the area to ensure that services are not being duplicated. And finally, virtual service delivery was imperative during those early phases of the pandemic. However, for some populations, continued virtual offerings are going to continue to be necessary. And so this can be individuals living in rural areas who have transportation concerns or childcare barriers. But as we heard from our first presenter, those virtual service offerings aren't going to be a fix-all for all of these issues. But in integrating virtual services into our regular service offerings, organizations may be able to serve a broader population, including hard to reach groups, than if virtual services were discontinued altogether as we move back into the new normal. Next slide. And so we did also have recommendations for FORE and for other foundations and grant serving organizations. And so as you've heard, this round of funding was a clear success. And one unique aspect of the funding was a zero cap on general operating funds. And so these general operating funds provided the chance for organizations to build the infrastructure, such as computers and Zoom licenses. And these infrastructure enhancements strengthen the organization's general capabilities. And this is going to allow for the sustainment of these programs or services beyond the life of the funding. Also, grantees overwhelmingly reported a desire to learn what other organizations had done, what worked well, and what unanticipated challenges arose. And so continuing to foster collaborative learning environments, or sometimes called communities of practice, is going to continue to benefit both the more established organizations and, more importantly, newer or smaller organizations that have similar programs or are beginning to build those programs. And finally, we recommended that the foundation establish a mechanism for quick response initiatives. So this program of funding really highlights the importance of reducing the time from request to proposals to funding when faced with an emerging public health threat. And this rapid response funding provided an opportunity for grantees to test innovative programming in real time. And so we want to thank the foundation and all of the grantees for inviting our team at RTI to be able to document the challenges, but also these amazing successes of meeting the needs of individuals living with opioid use disorder during this truly paradigm shifting time. And so with that, I will pass it over for the Q&A.
Thank you so much, Jessica. And thank you everyone for your presentations. I'm just going to take a second here to pin everybody so we can start this conversation. Hold on, let's do this. All right, so let's start with, let's go, oh, I'm so sorry. Let's start with a question for Hansel. You know, you mentioned Archer. And, particularly, I remember at the beginning of your project, you expressed, an interest in learning how to be a better supervisor to a peer. So I just wanted to hear a little bit about your experiences as a clinician supervising someone in recovery that has lived experience in your program, and what have you learned that you can share with people about supervising a peer?
Wow. Okay. So
Did I start off strong? I don't know.
there are, you started off strong. There are challenges with having people with lived experience on the team. Arrow was the first peer that we were able to hire at the University of Miami. And of course, there were the challenges with convincing the university based on arrest records and convictions that Arrow was a vital, that we were, he was going to be a vital member of our team. But as he's always with me when I teach, he's always with me when we plan grants. The university quickly learned his value. The reason the question is really loaded is our first two peers actually at IDEA did pass away from overdose. And this was before I was prescribing buprenorphine regularly. And that weighs very heavily on me and probably will for the rest of my life. In terms of supervising Mr. Archer, it's tough. Mr. Archer, I'm allowed to speak. He's completely transparent, so I'm not breaking anything here. He's very transparent with all of our students. He wants people to know his story, and usually he would be with me, but he is actually in treatment right now, and that is going to be part of our system of making sure. Arrow had decades and decades of homelessness, decades and decades of injection of heroin. I think from the time he was in his 20s to when he came to join our team at age 59. So I just have to be extraordinarily attentive to his needs, and I hope that this time, as things were becoming a little bit more challenging, we were able to recognize that perhaps a month-long vacation with his fine University of Miami insurance would be something that would be helpful to him. And it has been. He's actually coming. I'm picking him up on Sunday to come to our team pool party on Sunday. And we're just, I see pictures of him now, his skin, his voice, he's so happy. But it's been a challenge. I did not know how to supervise a peer, particularly a peer who is my patient. And then, but since that time, we continue in pursuit of making sure that IDEA is reflective of the community that we serve. And we are not dissuaded by the fact that it's a little bit challenging to supervise people who have substance use disorders and mental health disorders. And we have hired 3 additional peers on our team. So we are in this, nothing without us, nothing for us without us, and we are pushing through. But my main goal is to make sure that we don't have the tragic losses that we had with our first 2 peers. And if that means a little bit more engagement, a little bit more challenge, some intermittent vacations, so be it. And here we are.
And but I think those experiences and sharing that, especially with this big push to have peers in every emergency room, in inpatient settings with clinicians supervising, I think it's going to be really important that these individuals are different than medical students, than residents and such. So your experience is going to, and maybe documenting that to help others might be helpful. Speaking about lived experience, Casey at Ballot, you mentioned. The former Ballot employee, Jason Pritchard, who was, a part of building this program, someone who was himself, with lived experience in incarceration and in recovery. So I want to know, why was it so important for you to involve, Jason, to bring Jason on, with that firsthand experience with addiction in shaping the entire program?
Well, like I shared, I'm not a person in recovery. My brother is in recovery from heroin addiction. So I think just being a family member and walking through that path with him and realizing that so many times I had personally leaned on his lived experience for advice. And as I moved into this world in a professional setting, I thought, what better than to involve someone who actually had lived through the disease of addiction and who had been incarcerated to bring the lens of experience to the table. And so that he was very instrumental in shaping the program. And it's been very important to our program that we continue to involve the voices of folks with lived experience, not that we just hire them, but they are a part of steering the program as we continue to connect to individuals who need these services.
Great. And I'll make a plug for FORE really quickly. We are performing a national peer recovery survey. Believe it's the first of its kind, with a number of states, trying to get better understanding of the peer recovery workforce going on in the United States right now. So we have a question. I believe this is for Savick. So this question is, I'm guessing it's, with your program. So how did you handle the medical billing, including reimbursements from insurance? And also, did you take advantage of other supportive services or direct your clients to services such as vocational rehabilitation services?
Yeah, so great question. One of the extremely amazing benefits of the agency that I work for, Renewal House, is that none of our clients ever pay for any of our services. So we will bill TennCare for the extent that TennCare, that is the Tennessee version of Medicaid, for the extent that they will pay. And our clients never know when that starts and when that stops. So any thing above and beyond that is something that we pay for with a grant. And so thank goodness for this particular grant, FORE actually funded the position that was able to provide a lot of these services. And so we were able to offer these free of charge, like truly free of charge. When I think about Renewal House programming, it's a little bit different than a typical business model. So if you're a business person, just like close your ears right now. But we say, or I say, we do things because it's the right thing to do, not because it's the easy thing or the monetarily right thing to do. And so I think that really was sort of our motto in this whole treatment program. It was much more about getting services out there. And so they were truly free.
That's fantastic.
Yeah.
And I know you mentioned a few times, that some of the issues that you were solving were, quote your word, simplistic. But I can tell you, with our new CBO RFP, just kind of the application again, I think a lot of small organizations out there, are struggling right now and need those basic needs, such as, being able to hire a peer or just have that internet services. So I don't think they're as simple as you say. And I'll go to Jessica now. I think, you talked about the need for flexibility amongst these organizations. And that's what, I think the work that you did, as well as hearing from grantees about the needs right now on the ground, that's what led us to opening up this new RFP on community-based organizations' needs. I just wanted to hear a little bit from your perspective of, what do you see as those needs right now? I know there's workforce issues. There's obviously, people want to get more prevention programs up and running. What have you heard, in your conversations as to what these small organizations need right now?
Yeah, I think we even need to take steps back, thinking about things like we're seeing, now that different safety net programs are starting to be relaxed, that we are expecting that homelessness is going to increase. And so with that, how do we make sure that people have valid driver's licenses? We're about to go into election season. Are people registered to vote? And so how do we fit that into all of the other things that we do? And so I think, again, one of the things that was really exciting hearing across all the grantees was having that flexibility. It wasn't just, this is funding to hire the staff member. It's the staff member, and we can pay for calling cards so that people don't have to use their minutes to be able to do something. Hearing one of the grantees hired a web developer because they realized their website was so outdated that yay, yes, they're offering virtual recovery groups, but nobody can find them because the website's outdated. And so I think being able to have that flexibility and think it's not just the people, it's also these real wraparound services that, you know, everyone was mentioning that I think we need to address. But really thinking outside of the box of how do we help individuals to have what they consider to be a healthy life and to be able to sustain their recovery. And sometimes that doesn't have anything to do with their substance use.
Yeah. And I know that grantee, Young People in Recovery, because of that, they were able to reach, you know, over 17,000 individuals during COVID. So just, you know, that simple investment to just build a better website made a huge difference.
Exactly.
Yeah. So this is, I guess, a question that goes to Hansel, Savick, and Casey. You know, so how do you ensure, you know, as providers or, you know, running programs in these kinds of clinical and medical settings, that you provide recovery-friendly environments for peers to be able to work? And I know, Hansel, you got into it a little bit already, and I know it's your perspective, but thinking about it holistically in the health system, how do we do that? Or how do we approach that? So Hansel, you could go first.
I mean, I can speak of our own experience. You know, working in harm reduction is challenging for everybody, peers, myself. I just got back from 3 weeks of vacation on Martha's Vineyard, where my governor just sent a couple planes of migrants, but that's a different conversation. And that was what I needed to recharge. We definitely like to make sure that everybody on staff has that time to recharge. We're currently looking at administrative 1 work from home day per week so that people aren't in the constant fray of being at IDEA, because IDEA is our program is controlled chaos. So it's very important to be able to remove oneself from that. But in the example that I was giving of Arrow coming to the team party on Sunday, I polled the peers on staff, and then even before they all answered, I made the decision that it was going to be a dry party, even though we have a staff of 20. That we were going to have a dry party, because I personally don't think it's fair to Arrow to come out of treatment for the day and to be surrounded by you know, that sort of festivity. So, you know, it's important to always consider that there are people who have additional challenges. I mean, everybody who works in this space is kind and is considerate of other people, and we just have to remember, particularly for those of us who don't have substance use disorders, we have to remember to consider the challenges that are presented to those peers in their service of our community.
How about you, Savick, in a residential setting? I guess how does that work?
Yeah, so I think it's really interesting. We really take the concept of peer in a little bit different way. And so instead of having a traditional peer, we've had one in the past, we don't have one currently on staff. We actually have a lot of our professionals, whether they are our administrators, our social workers, our therapists, with lived experience. And so it's not just having someone with lived experience who's necessarily acting as a peer, but someone who has, say, my office manager has 27 years of lived experience, right? And so her running our office brings this whole different feel of what that's like when a client comes to our office 24 hours a day, 7 days a week, and it impacts the way she trains her staff to interact with our clients, right? And so we have, oh my goodness, maybe 40% of our staff right now has some type of lived experience. It's really amazing. And it brings so much to our team. And so we talk about trauma-informed care for our clients, but that really does spill over for your staff. And so like Hansel just said, we actually have really tried to be very purposeful with self-care for our staff. We actually just offered our staff the ability to work 4 10-hour days instead of, you know, 5 8-hour days. I say that backwards every time. And, you know, almost everyone took us up on the offer, right? And so we want to, again, we work in sort of organized chaos in a residential setting with 34 women and, you know, up to 50 children. it's chaotic. And so how do you take care of yourself? And we know a good portion of our supervisees or individuals that we work with are in recovery. So, I have a couple and I'll tell them, you're having a bad day and you need to go to a meeting at lunch, go to a meeting at lunch. Like, that is amazing. And then lastly, I'll say we've strategically developed a culture at Renewal House, and we do something called SNOOP, which is SNOOP. It's Staff Nurturing Other Outstanding People. And you just send an email to our director of operations, and we have this little SNOOP committee, and it's just little anonymous emails. And every month we send out an email blast to our whole team that just says, hey, we noticed this person doing this awesome thing and this person doing this awesome thing. And maybe like once every other month we have our SNOOP committee. We do something fun. You get like a little treat in your mailbox that's based around Halloween or whatever season is coming up. And it's not a lot, and it doesn't cost a lot of money, but it makes a big difference. We have a chili cook-off, which, Pamela likes to say she won. She did not, but I did get second place. So it's about nurturing your staff.
Exactly. No, I love that. I really do. And Casey, how does that work in a multi-state large health system? There's a lot of different players and a lot of different interactions.
Similar to what both Savick and Hansel shared, and I think too, just being an understanding employer, like you said, knowing that lunch may mean that this individual may need to go to a recovery meeting, or maybe we have staff actually that are still on probation or parole. So that may mean that on Thursdays they have to leave early to go to a probation meeting. So just being understanding and flexible and realizing that we need to also meet our staff where they are. And also educating my colleagues in the health system. When we first started hiring peers, there were a lot of conversation about, as healthcare providers, we think about credentials, and certain licensure means a certain qualification for a person to fulfill a role. And really talking about understanding that lived experience is a person's qualification in these roles, and that we can't, ask for someone to be, bring their lived experience to the table, but then also expect them to be a person who's extremely well educated on how Outlook works and things like that. So really understanding to embrace the person and appreciate the skill set that they bring to the table. And also, like you said, having the meetings. We had one last Friday where we had 2 hours of a meeting, and then the rest of the afternoon we enjoyed a meal together, and we let the peers, talk about their wins and their challenges, and just creating a network. And everyone except for myself in this department that are in supervisory roles are peers. And I think that's very important, because they can pick up on the folks that report to them if they're having a hard day or need a moment for self-care, maybe even more quickly than I could, as someone without lived experience. So
that's great. Thank you. Thank you for sharing that. So that brings us to the end of our right on time, 4:30. That's incredible. We were sorry that we couldn't get to everybody's question. We are going to publish, a Q&A on our website that's going to be posted along with the recording and the slides. That should be up by tomorrow, I would say, Q&A by Monday. But really, we appreciate all of our presenters' times. Thank you so much for being able to be here and present to everyone. And we thank all of you for joining us today to listen to some of the great work of our grantees. And with that, we hope you take care of yourself, and thank you everyone for your work. Hope everyone has a great rest of the week.
thank you.
Bye, everyone.
Bye.